So Tufan, I've got a really complex case. We are a level 1 trauma center, and so I see a lot of patients with pelvic trauma, urethral trauma, and I ended up with treating this woman. This 58-year-old came to me, and she'd had a history of a pelvic fracture and had stabilization of her pelvic fracture, and this was 5 years ago. I actually saw her when I was on call at the time of her pelvic fracture, and there was a extraperitoneal bladder injury. We placed a catheter, and it healed. However, she went on to develop stress urinary incontinence, and she had come from a location, since we are the only level 1 trauma center in a very large catchment area. She came from a remote location and developed stress urinary incontinence, and at an outside hospital underwent a pubovaginal sling for treatment. So I applaud them for being able to do that in the context of her complex pelvic fractures. But she came back to me because now she had this sling placed, and now she has recurrent incontinence. And it's very difficult sometimes for her to define, although she really believes that this is primarily stress urinary incontinence. It is with any type of activity, and she doesn't endorse much of an urgency component. Her PVR is 0, so we did a uroflow in the clinic. So thankfully, she's able to empty. But when I did her exam, what was notable was a very fixed urethra. And as a matter of fact, I was concerned because I've seen, after pelvic fractures, things like bony fragments and whatnot. And I actually did a cystoscopy at that point, and it was very atrophic and very fixed. You could tell that there was very little coaptation, but her bladder neck looked a little unusual as well. So do I just move forward in this situation and place another sling?
Oh, well, of course not. I wouldn't do that. This is a complicated case, really. Interesting that, she is leaking so heavily after the pubovaginal sling. So she has probably a strong or complete or significant denervation of the urethra or injury to the sphincteric system. So she has a very low outflow resistance. And it is very likely that she has, for that reason, an intrinsic sphincteric deficiency. I would certainly would like to see a multi-channel urodynamics for this lady, and then to decide on further what to do. So this is my basic evaluation or method for this lady at this point.
And we did. We proceeded with multi-channel urodynamics. Do you believe that there's utility in this situation to employ video urodynamics?
Yes, if you have the chance to reach a video urodynamic study, certainly yes. Video urodynamic studies are not included in the ICE's standard urodynamic testing, but they are considered again as the secondary diagnostic urodynamic tools by the ICS. They are very valuable, especially if you would like to combine the anatomy with the function of the lower urinary tract. I can describe you some valuable patient descriptions for that. For example, young men and women with the pre-diagnosis of bladder neck dysfunction or dysfunctional voiding, or with neurogenic patients, especially the children with spina bifida, who are at risk of also developing reflux and upper tract damage. To diagnose the reflux in that patient group and correlate it with the bladder capacity and the bladder pressures are utmost or of utmost importance here for our decision making. And also patients with congenital or acquired anatomical abnormalities, like you have here also in this case scenario. You have here a patient who is neurogenic, who has a neurogenic lower urinary tract dysfunction, maybe together with some anatomical abnormalities. So I think my answer to your question would be yes. So if I had the ability to reach the video urodynamic study, because we know that it is not available in every center, I would certainly go for it.
I concur completely. And when we look at her multi-channel study in this situation, what it demonstrates is relatively stable bladder filling, thankfully. She doesn't have much detrusor overactivity, but she has exceptionally low leak point pressures. And there was funneling, and you could see a widely patent open bladder neck throughout the entirety of the study. So it was close to gravitational incontinence. And what we also see on this study that is highly important is what happens on her pressure flow. When she's asked to void, there is minimal to no increase in any detrusor contraction. So the reason that in this situation where you have basically a neurologic injury to the bladder neck, the only reason that she has the capacity to void completely is because there is no outlet resistance. So in this situation, no detrusor overactivity, almost gravitational incontinence, and detrusor underactivity, how would you counsel this patient?
Again, this is a really complicated situation. So what we have in our hands is, first of all, a severe intrinsic sphincteric deficiency in neurogenic origin. So I would like to counsel with the patient here, starting with the least invasive, although it is not the most successful one, with the least invasive option, which is an injection of the bulking agent here. So I would start with a bulking agent here and see how she responds to that treatment. And of course, this will increase, hopefully, the bladder outlet resistance and maybe just serve to her already significantly impaired continence mechanism. If this fails, of course, if the compliance, as far as I can see, her compliance is good, Melissa, am I right? So her bladder capacity is good, compliance is good. So she may be a candidate for artificial urinary sphincter as well. So I know that it may still not be not approved in the United States, or if I'm wrong, please correct me. So in this case, artificial urinary sphincter could be a good option if the bulking agent fails. And of course, we can also discuss the option of urinary diversion with her. If we cannot, use the bladder outlet, then closing the bladder outlet and then do a catheterizable stoma for her could be the last option, according to my initial thoughts now.
Well, those are exceptionally insightful. And indeed, we did begin with bulking agent, to which she had a modest response, but was still able to empty her bladder. It waned over time. And being that we do not have available in the U.S. the artificial urinary sphincter, which I believe would have been the ideal situation for her because it allows complete ability for her to empty. It won't change the resistance during emptying, but would accommodate her storage. The complexity in performing that procedure in this particular setting would be the history of her pelvic fracture and pelvic dislocation in anterior plate, because it would be my preference in those situations in women to perform it robotically. But this may or may not have been feasible in her, but it was a moot point because we don't have it available as FDA indicated in the United States. But I believe that dynamic may change in the future too, particularly with newer technologies that don't have the labial pumps that will be Bluetooth actuated. We may have further options for women for treatment of stress incontinence with artificial sphincters. In this situation, the discussion then became, if we change your outlet resistance to a point where you will now be continent, we have to come up with a strategy for bladder emptying. And so the two options were, just as you mentioned, catheterizable channel, or in her situation, she chose to undergo intermittent catheterization. So what we did was perform a second pubovaginal sling and made it exceptionally tight. And so we basically closed her outlet successfully, and then she performs intermittent catheterization to manage her bladder. And she is continent, and she is quite pleased with the outcome, considering all the other potential interventions. We did offer, again, the catheterizable channel, and for some patients that would have been a more feasible option, but she became very agile with use of intermittent catheterization. But the study itself completely informed our counseling of her and what to expect. She had never heard after her first pubovaginal sling, which thankfully was not put in a way that allowed her to be either continent or obstructed. Thankfully, right? She had no concept that she might have this issue following a sling procedure.
Yeah, I agree. Anything that you would offer for the lady will have a less successful outcome and will be more complicated compared to a treatment-naive patient. I agree with you that inserting or implanting an artificial urinary sphincter will not be easy after this pelvic fracture and after the operation of a pubovaginal sling. It's because the pelvis will be very hostile for the surgeon for that reason. And I'm estimating that also putting another pubovaginal sling should be done very carefully, only in expert hands. Maybe this may be the take-home message that we can deliver from this case. I mean, these kind of cases should only be handled in tertiary referral centers like yours and in very experienced and expert hands.
Thank you.
Thank you.